Hey, so right now we're going to be talking about digestion, the entire GI tract. Well, actually, the first part of the GI tract, how food goes through it in a variety of species. Okay, now that the computer's working, let's start with the pharynx. The pharynx is the common passageway for both the digestive and respiratory systems. The nasopharynx is the part of the respiratory channel. It lies dorsal to the soft palate, so it's above the soft palate, and it extends from the caudal nares, so just behind the nasal openings into the nose, to the laryngopharynx, which goes all the way down to where the larynx is. The oropharynx, which is part of the digestive channel, lies ventral to the soft palate and extends from the oral cavity, the mouth, to the base of the epiglottis. Now, there are some species differences within, the horse versus the cow versus the dog and cat, and the when we're talking about birds, especially, or reptiles, it's very different. I do have a video of the respiratory system of the horse. I will post this for you on your eLearn page, and I definitely want you to take a look at that. And so we'll continue. There is something called a pharyngostomy. Now remember, stomy means an opening or a mouth into something, and in this case, it's the pharynx. A pharyngostomy is a surgical incision into the pharynx, and we can actually pass a tube through that pharyngeal wall and down into the esophagus, into the stomach, for dogs and cats who can't use their mouth. So if they have difficulty eating, don't want to eat, we want to feed them relatively easily, we can perform this pharyngostomy. I actually have this is not a pharyngostomy, but an esophagostomy feeding tube placement. It's relatively easy to do. It's something that a technician can actually do as a specialist, and it is something that you can do in your clinic, or a doctor can do in your clinic. So I do have a video. Again, I will post this on your eLearn course shell so you can take a look at this as well. All right, so let's look at, here's the mouth, okay? And we're talking about the oropharynx, which goes from the oral cavity in the mouth here all the way back to the esophagus here. This is the oropharynx here. This is the nasopharynx, the nasal passages back to the laryngopharynx, which is back here as well. Now remember, we have the windpipe that comes down here, and when we have an animal breathing, then we're going to close off the esophagus and open up the windpipe. So this, generally speaking, the epiglottis is up here, not covering the windpipe. When we're swallowing, on the other hand, it will push the epiglottis down so that we can get a straight shot down here into the esophagus. So when we're swallowing, this is closed off. When we are breathing, this is opened up. So what covers the esophagus, or even the mouth into the esophagus? It's a thin covering of mucosa, and there is in the esophagus very thin muscular tissue, and they're longitudinal muscle fibers, so they go from the top of the esophagus down into the stomach. This tissue is separated from the acid of the stomach, which can do a lot of damage, by a very weak valve. Now, I don't know if you remember me talking about this weak valve that is between the stomach and the esophagus, but it can be called a couple of different things. It could be called the esophageal sphincter or the cardiac sphincter. It's called the cardiac sphincter because it's right near the heart. And there's also a fold in the stomach that keeps the acid within the stomach as well. So it's kind of a double gate here to keep the acid in the stomach so it doesn't come up and damage the esophageal wall, that very thin covering of mucosa and that thin muscular tissue. Any damage to the epithelium, which is either through caustic substances which are swallowed or from caustic stomach acid, can be significant. It can cause perforation, or the damage can cause or stricture, and this perforation or damage, that stricture that is caused, is from scar tissue formation. The esophagus does not like to be hurt. So anytime it is hurt, it really puts together a really big immune in our inflammatory response. And as part of that inflammatory response, scar tissue comes in. When scar tissue comes in, it contracts. And when it contracts, it can make that esophagus smaller than normal. So when we have loss of normal muscle tone, we can also see this in myasthenia gravis, which is an immune-mediated disease. The myasthenia gravis, it's the immune-mediated. It's when the body's immune system actually attacks the nerve receptors that cause esophageal muscle contraction. So it stops muscle contraction, and we get full relaxation of this normally tight muscular tube, which will then lead to stretching of the tube. So this will cause a problem with the esophagus, in which we have a megaesophagus, something really big. And actually, you can see this here. We have a much bigger esophagus than normal. Should normally be about the size of this trachea, which is here. And you can see air in the trachea. That's the black stuff here. You can see with this esophagus that we have a stricture here. There's a point within the esophagus where it is completely scarred down. Now, part of this could be peristalsis, but honestly, with the esophagus, we don't see extreme peristalsis as much as we might see in the intestines. And so what we're seeing here is a stricture, and in front of that stricture, we have an enlarged esophagus. We even have a big esophagus beyond that stricture as well. So this flaccid enlargement of the esophagus that doesn't push food down into the stomach causes chronic regurgitation. So food is constantly falling out of the esophagus, falling out of the mouth. And when that happens chronically, over time, we have much more increased risk of aspiration pneumonia. So the esophagus, its function is to conduct swallowed material to the stomach. It's not part of the digestion. There's not any significant absorption that takes place. It is just a transport tube. That's its only job. And when it messes up on its only job, we can have a major issue. The lower esophageal sphincter controls the movement of that bolus of food, that's the chunk of food that we have swallowed, into the stomach. And as the stomach expands with food, the fold that I said that was part of the closure of that stomach into the esophagus, it acts as a natural valve to close the lower end of the esophagus and reduce the risk for reflux. So what is reflux? Reflux is when we have acid material or stomach contents coming up into the esophagus. You've probably heard of esophagitis or esophageal reflux or GER, gastroesophageal reflux. This actually causes some major issues in babies and in adults. What is it? It's heartburn. Now remember what I said about this. There's a cardiac sphincter. That sphincter is very close to the heart. What is heartburn? It's the actual acidic burning of our esophagus. When somebody has heartburn, it's typically because they've eaten a food that doesn't sit well with them. It creates a lot of gas in their stomach. That gas will bubble up, and that weak valve will open, and you get stomach acid floating up into the esophagus, and that causes heartburn. And that's part of what we see with reflux. In some species, they actually have a really good anatomical closure. And it's so strong that they actually don't get reflux, and vomiting is nearly impossible. The two species where we see this most often are in the horse and in the rabbit. They cannot vomit. In the monogastric stomach, like ours, we have one stomach. There are 5 different areas of the stomach that I want you to be aware of. The cardia or cardiac sphincter, which leads into the esophagus. The fundus, which is the blind end of the stomach. Food comes down in here, comes into the fundus and in the body. Within the fundus and body, we have a lot of glands, a lot of gastric glands. They are made from parietal cells, which make hydrochloric acid, chief cells, which make pepsinogen, and mucus cells. Mucus as an adjective is O-U-S. Mucus as a noun is spelled U-S. So there is a difference between the two of those. Mucus cells, M-U-C-O-U-S, make mucus. So that's the fundus in the body. And then we have the pyloric antrum, which is below the body, and it's what leads into the duodenum. The pyloric antrum leads to the pylorus, or the pylorus valve or pyloric valve, which leads into the duodenum. The pyloric antrum has glands that contain G cells, and these are endocrine glands, and the G cells make gastrin. Gastrin is an enzyme that is produced when it comes in contact, when the food comes in contact with these glands, and it helps to regulate the production of hydrochloric acid. So all of this stuff is working together. Chyme, CHYME, is what we call digested stomach contents, and it's what is pushed from the stomach into the duodenum. Rugae or rugae are these multiple long folds that are within the stomach, and it helps to increase the digestive surface area. It also helps to allow the stomach to stretch as it contains more food. So the cardiac opening or cardiac opening in the esophagus, from the esophagus into the stomach, with that lower esophageal sphincter or cardiac sphincter here. The fundus is adjacent to the cardia. It is a blind end, meaning it doesn't go anywhere. There's no tube coming off of it. And it is the expanded portion of the stomach on the left side of the stomach. So the stomach should always face in the same direction. It's often filled with gas. Okay, so gas rises, so that makes sense. The body is the largest part of the stomach, and it is here. And in the pylorus is the distal opening of the stomach, and it's surrounded by a strong band of circular muscle, and the stomach contents from here, that chyme, enters into the duodenum through this pyloric sphincter. So there are a lot of words here, and these are words that I want you to be comfortable with. Normal gastric motility. So there is a swallowing reflex, and that swallowing actually relaxes. It's when that swallowing occurs, that relaxes the fundus in the body. It's allowing the proximal portion to fill with food or liquid. Then the body of the stomach will contract to mix the stomach contents, and swallowing will also increase contractions in the pyloric antrum or distal part of the stomach, which allows for vigorous mixing and grounding and movement toward the pylorus. So swallowing creates an effect in the stomach. There's another reflex that I don't have here, which is the gastrocolic reflex, which is when your stomach is full, your colon actually will be stimulated to move. And so if you've ever noticed, when you have, or if you have a baby, this is something that happens very quickly, or a puppy, they eat and then they go poo. So within an adult, it takes a little bit longer, but usually within an infant, you have them eat, and within 20 minutes they go poo, and that's called the gastrocolic reflex. And it's not, the food that they're eating isn't what's coming out. It's just that the stomach, as it expands, causes the colon to move and move fecal contents out. Peristalsis is when the longitudinal muscle fibers from the esophagus through the stomach and actually all the way through the intestinal tract contract and move the food along, gets it moving in the correct direction. There are circular muscle fibers in the pylorus that maintain constant tone, but it's not completely closed. So we have to think about that. What moves through more easily, liquids or solids? So solids are going to move through, less easily. Solids will move through less easily. Chyme will be pushed through that small constant opening. So food needs to be properly digested before it gets into the duodenum. Again, these will be links on your eLearn course, and you can play them there. Stimulation of the stomach is a smooth muscle response. The stomach is a smooth muscle, an organ muscle, not a skeletal muscle. So stimulation is automatic, and it's not, you don't control it. It's by the parasympathetic nervous system. Remember, the sympathetic nervous system, which is below here, if the sympathetic nervous system is activated, that's fight or flight. Stress, surgery, illness, all of that can decrease muscle tone, causes gastric atony. Gastric atony occurs when we have stress. Your stomach is not moving. So it is stimulated by the parasympathetic nervous system, specifically through the vagus nerve, which is cranial nerve 10. And this causes the fundus to relax and fill, and the antrum in the body to contract for mixing and peristalsis. Remember the gastrin, the G cells in the antrum, or the last part of the stomach, those G cells make gastrin. Gastrin increases the production of hydrochloric acid in the stomach. It also inhibits the muscle activity of the fundus. So by doing that, it promotes the breakdown of food. There's the enterogastric reflex, which results in delayed gastric emptying if something is causing the intestines to be distended, or if there is an increased acidity in the duodenum, because that means that the duodenum is not ready to handle any more chyme. So that enterogastric reflex will slow the process of the emptying of the stomach if it seems to be something stopping the movement of food through the intestines, or if there's too much stomach acid getting into the duodenum. It's important to remember, because if animals have some sort of stoppage or increased gas in their intestines, this will cause their stomach not to empty. They will feel full and they will not eat. With gastric secretions, we have a couple of other gastric secretions beyond gastrin. We have secretin, which is a hormone that is released from the duodenum in response to increased stomach acid in the small intestine. This causes the fundus to relax, and it inhibits peristalsis, or slows gastric emptying. So secretin is that hormone like gastrin, and it responds to it also increases stomach, or it's in response to stomach acid in the small intestine. So it's a part of the small intestine. Cholecystokinin is released if there are large amounts of fat or protein in the duodenum, and it decreases the contraction of the antrum and the body, just like secretin, and the fundus like gastrin. Right, the submucosa of the stomach contains gastric glands, which secrete enzymes, mucus, hydrochloric acid, and a protein called intrinsic factor. And in many species, it's this intrinsic factor that has to be there. It has to combine, or it needs vitamin B12. If we don't have vitamin B12, we have a problem. So intrinsic factor must combine with vitamin B12 so that the vitamin can be absorbed into the small intestine. So we need those things to work together. All right, so a little bit more in picture form of what we're looking at. So within the stomach, we have vitamin B12, which is also known as cobalamin. Cobalamin mixes with intrinsic factor, and when it mixes, it can get into cells and be absorbed. Vitamin B12 is important for metabolism, the formation of red blood cells, and the maintenance of the central nervous system, which includes the brain and the spinal cord. So if we don't have intrinsic factor, we cannot absorb vitamin B12, and that's critical to our function. All right, some more gastric secretions. There's a lot of secreting going on here. Pepsinogen is made by chief cells, and it is the precursor for the hormone pepsin. Pepsin is a proteolytic enzyme. Proteolytic means it breaks down proteins. It is actually activated by hydrochloric acid. So the proteins are broken down by pepsin and form chains of amino acids, which are later broken down even further in the intestine. The pepsin is inactivated in the more alkaline pH of the duodenum. So it works in the stomach, but when it gets to the duodenum, it stops working. There's also mucus. Mucus is produced by the gastric glands and is a complex of many different substances. It provides a gelatinous coating, protective coating. If we don't have this mucus here, we don't get protection of our stomach lining from the hydrochloric acid. Mucins are complex molecules. They're made by goblet cells. So if you want to think of it like this, a goblet is a glass, or a kind of a wine goblet. Think of a wine glass. Think of it full of mucus, or mucins. So goblet cells make mucins, and that's the main part of the mucus coating. Bicarbonate ion is also secreted onto the surface. It's an alkaline mucus coating that helps to neutralize or buffer the hydrochloric acid to some degree. pH is about 2 to 3 in the stomach. That is very damaging to tissues. We have to have that mucus to protect it. Mucin is not digested by pepsin because it's not a protein, but it is fragmented by the hydrochloric acid. So all components of this must be secreted continuously. So mucin will be broken down over time, so the goblet cells need to keep pouring that mucin out onto the surface of the stomach. There are parietal cells within the stomach wall. There are 3 receptors on the blood side of the cell versus the stomach or lumen side of the cell. They regulate acid production. There's a gastrin receptor. Remember, gastrin helps to regulate hydrochloric acid. There's an acetylcholine receptor, which is part of the parasympathetic nervous system, which tells the stomach to release secretions and also to increase its contractions. And there's also a histamine or H2 receptor. That histamine will help to protect the lining of the intestines as well. We have to have stimulation of all 3 to result in the optimum amount of hydrogen and chloride secretion. If we don't have the stimulation of all 3, we may have a decreased amount of hydrogen and chloride so that we don't get the breakdown as well. Now, this can be used to decrease if we're having an overproduction of hydrogen chloride because of a disease process. Then using a histamine blocker, like an antihistamine, specifically one that blocks H2 receptors, like Tagamet or Zantac, those are histamine blockers, that will bring down the level of hydrochloric acid in the stomach. All right, so let's put it all together. Gastrin is released from G cells in the pyloric antrum when the body and the pyloric antrum are stretched. So when food enters the stomach, gastrin is released. That gives us more relaxation of the fundus and an increase in production of HCl. So food is going into the stomach, and as it does, it allows the stomach to stretch more and acid to come in to help break down that stomach contents. When the pH of the stomach goes below 3, then gastrin release is inhibited. So we no longer have gastrin release, and so going to drop. We're not going to get as much sodium or hydrogen chloride, so not as much acid, and the stomach is not going to be as relaxed anymore. If we block any one of those parietal cell receptors, that'll decrease the production of the stomach acid. Just like I said, if we use an H2 blocker like cimetidine, which is Tagamet, or ranitidine, which is Zantac, they block that. It's also how atropine, which blocks acetylcholine, it's an anticholinergic or acetylcholine blocker. It also decreases acid production. So that's one of the things that we use when we're trying to block the parasympathetic nervous system. So gastrin is decreased when we decrease our pH. When this acidic chyme goes into the duodenum, it helps to release that CCK, which is cholecystokinin, and it also releases the pepsin to break things down. So that's how everything works together, and there's a negative feedback. So when we get this acidic chyme into the duodenum, we've got a negative feedback to enterogastrone to stop the production of gastrin. All right, so working stomach, again, I'm going to have this ready for you on how everything works within the stomach. You can take a look at this, take a break now and go look at all those videos for me. All right, so we do have prostaglandins that work in the digestive tract. So if you remember back to our lecture on all the chemicals that are going on within the body, prostaglandins are a certain enzyme that can have good effects and they can have bad effects in the body, but they're basically just a part of the homeostasis of the body. With prostaglandins, they are the end product of a cascade of steps in inflammation, so they can cause redness, swelling, heat, pain from injury or disease. And as long as that inflammation isn't too bad, you probably should just let it do its work because it's actually it's healing you. We can block it if it's getting a little bit out of hand, so we can use non-steroidal anti-inflammatories to block these prostaglandins like aspirin, carprofen, which is Ribadyl, or meloxicam, which is Metacam, and that will block the production of inflammatory prostaglandins. But prostaglandins also support certain things in the body. So they regulate blood supply to the kidney, they regulate a normal estrous cycle, they maintain the normal health and stability of the GI tract, and protect the lining of the GI tract. So if we're blocking too many of these good prostaglandins, we can get some problems within the GI tract, within the stomach, and within the normal estrous cycle. Prostaglandins type E and G, PGE and PGI, are the ones that help to reduce the stomach's hydrochloric acid production by inhibiting gastrin release from, do you remember the cells that gastrin comes out of? You should know that. They're the gastric, the G cells. So gastrin comes out of G cells, okay? So they also, prostaglandins also inhibit parietal cells. Now they inhibit all of the parietal cells, all the receptors within the parietal cells. They also stimulate production of bicarbonate ion. They enhance blood flow to the stomach. They stabilize potentially destructive lysozymes within the gastric cells, and they regulate the activity of macrophage and mast cells. So they are there to help repair any damage to the stomach epithelial lining caused by a break in the mucus barrier. So if hydrochloric acid is being produced way too much, using something that promotes prostaglandins, these prostaglandins will be helpful to the GI tract. If we can understand all the complexities of the upper GI tract, it can help us to understand some of the diseases and the medication that we use to help to prevent or correct these diseases. Now, whenever we think of diseases, all diseases come in groups: inflammation, infection, immune-mediated, idiopathic, trauma, endocrine, or neoplasia. So there are diseases that we will see that are inflammatory, some that are caused by infection, some that are caused by the animal's own immune system, some that we don't know the cause of, that would be idiopathic, some that are caused by trauma, endocrine disease, or neoplasia or cancer. It's important to remember all of these, because if we can think through this in a very stepwise fashion, we can really understand what the cause of the symptoms might be that we're seeing in the animal. It will help lead us to a defined diagnosis. So whenever we're thinking of a diagnosis for an animal, we try to go through all these different areas from where this disease could be coming from. Some ways to think of it is to make a mnemonic of it. So Ivan itches in icky, terrible, elevated niches would be one way. And these are just silly things to try to help you remember that these are different areas that we need to think about when we're talking about diseases. All right. So monogastrics versus ruminants. So monogastrics, there are carnivores, omnivores, and herbivores that are all monogastrics. A carnivore would be a cat is a monogastric carnivore, and monogastric omnivore would be a dog, and a monogastric herbivore would be a horse or a rabbit. Ruminants are herbivores. So they have 4 stomachs, and camelids have 3, designed to help them digest food. We also have to remember we have avian digestive systems and then some completely different digestive systems within the reptiles as well. So let's just real quickly go through. We have our esophagus to our stomach, to our duodenum, to our ileum, our cecum, our duodenum to our jejunum, to our ileum, to our cecum, to our colon. Okay, so we have this going through here, and we can't forget the liver and the pancreas are helping out with the digestive process as well. So what's different about the ruminant? We have a rumen, esophagus to the rumen, to the reticulum, to the omasum, to the abomasum, and then we go through the rest of the intestinal tract. Avian has a crop coming off the esophagus, and then we also have a proventriculus and a gizzard going into the duodenum, into the cecum, into the large intestine through the cloaca. All right, so real briefly on birds. The beaks of birds are going to vary with their diet and foraging strategies. So I can show you some examples. and it's not going to the right slide. But we do have examples in this lecture, and I will show you those examples in a minute. Here we go. These beaks are for filtering. These beaks are for probing for insects. These are for catching insects, like little tweezers, so you can catch insects. These are for cracking seeds. This is for tearing meat, and here's one for drilling holes. Okay, so we have adapted beaks for different prey or the type of food we're going to eat. And then we also have some adaptations as far as their feet go as well. So beaks will enable birds to find, grab, and sometimes even kill food items. They allow them to tear food into smaller pieces to begin the digestive process. Remember, they do not have teeth to grind up the food, so that has to happen somewhere else. The bird's mouth has a hard upper palate, a softer lower palate, a distinctive tongue. Here's the tongue here. Salivary glands and scattered taste buds. The tongue aids in manipulating food and moving it to the back of the mouth for easy swallowing. In parrots, it's very muscular, but in many other species, it has just a few muscles and is moved by the muscles of the jaw apparatus. So when we are looking at the mouth of a bird, this is a bird with its mouth wide open. The entrance to the esophagus is all the way in the back of the mouth. The entrance to the glottis is up at the front of the mouth. Okay, so into the trachea, we're up at the front of the mouth. And then on the top of the mouth, we have the choana, which is the opening into the nasal cavity. The esophagus in a bird is a somewhat muscular tube that extends from the pharynx to the stomach along the right side of the neck. The lining contains mucous glands that lubricate the food to facilitate its passage into the stomach. Birds that have well-developed crops generally eat a few larger meals per day instead of foraging and nibbling all day long. So if we want to think of a very well-developed crop, we might think of a pelican who captures fish and then digests it over time. Little, if any, digestion occurs in the crop. Its main function is to store, lubricate, and regulate the passage of food. And in some species, it's modified for additional purposes, like the pelican. And in other species, they may store food in their crop in order to regurgitate it into an offspring's mouth at a later time. A bird's stomach consists of two separated components, the glandular stomach and the muscular stomach. The anterior glandular stomach is called the proventriculus. This structure is unique to birds and is the organ in which chemical digestion begins. So it's more like our stomach, our monogastric stomach. Its mucosa consists of columnar epithelial cells and mucosal glands that produce mucus to moisten food. There is a submucosal layer that possesses digestive glands as well. So it is where food is starting to the digestive process. These glands are going to secrete pepsin, which begins the breakdown of proteins, and hydrochloric acid, which increases the acidity of the stomach to enhance the action of digestive enzymes. In birds, the gastric juices can have a pH between 0.7 and 2.5. Now, if you'll remember back to the monogastric stomach and the pH, it was between 2.5 and 3. So this is way more acidic than you would find in other animals. The muscular stomach is called the gizzard, and it consists of distinct bands of striated muscles that work to grind food components such as bones, scales, and nuts. Many seed eaters and grain-eating birds actively seek and ingest small pieces of grit in order to help grind the food. In the ruminant, there is only one true stomach. Do you remember what that is called? It's called the abomasum. Okay, so what are the three forestomachs? We have the rumen, the reticulum, the omasum, and the abomasum. Rumen, reticulum, omasum, abomasum. The rumen is the largest compartment, and it fills most of the left half, displacing other organs to the all to the right of the abdomen. Its function is to start the digestive process. It actually is the fermentation, starts the fermentation of the food. It's filled with many papillae, or it has a pile rug appearance, just like this. This is the rumen. Kind of looks fuzzy, okay? The reticulum is just below the rumen, and it has kind of a honeycomb appearance to the inside. The omasum is called the butcher's Bible, and it has folds or leaflets. And the abomasum is where we have this true stomach, the glandular stomach. So the reticulum is that cranial compartment, lies against the diaphragm, has the honeycomb appearance due to intersecting mucosal crests. And that honeycomb appearance is simply to add surface area for digestion. The omasum, the butcher's Bible, or the book, has pages, looks like pages, and has muscular luminae. So this is where we have a lot of grinding occurring. The abomasum is an elongated true stomach lined by glandular tissue. Here you can see rugae, that like we would see in our own stomach. This is lined with glandular mucosa, similar to the simple stomach of the carnivore. All right, so clinically speaking, what is this? What are we going to be talking about? So bloat, for instance, and some of you may remember that we had a case study in intro class concerning bloat in a goat. That is the excessive accumulation of gas in the rumen and reticulum. And what we'll need to do typically is place a stomach tube to relieve that bloat. And if we can't, we'll have to trocarize that animal or stick a needle in it in order to release that gas. It's very important we get that gas down. If we don't, that stomach, because it is expanded so much, it will decrease the blood flow to the stomach or the rumen, and the rumen will die. And that's a problem. And again, I will post this this video here for you so you can watch it later. Hardware disease is another disease that we will see with digestive issues. Remember, we talked about this. It's when an animal swallows a metal object or something that is a foreign object that will actually puncture through the rumen and cause a peritonitis or a pleuritis, inflammation of the abdominal or thoracic structures. Also, a displaced abomasum. If the abomasum shifts far to the right or over to the left, it actually causes a problem with blood flow to the abomasum and to the rumen, and so we will get diseased and dead tissue. How can we tell that we have a small structure in the wrong place? We use the pinging method. If you remember, we want to place the stethoscope on the side of the animal and flick the animal's side and hear the difference between what a rumen is supposed to sound like, a very deep tone, like a timpani, and a abomasum, which would be a higher pitch sound because it's smaller. So if you think of what you would hear if you flicked a tennis ball versus a basketball, that's what we're talking about. We can reposition these and suture them into place. Okay, moving on to the small intestine. First of all, the duodenum. It's a short segment that leaves the stomach and it receives the ingesta, the chyme from the stomach. In the pig, horse, and ruminant, I have a species alert for you. There is something called the sigmoid loop. It is the cranial portion, the cranial portion of the jejunum. Okay, and this sigmoid loop looks like so. Again, it's in the pig, the horse, and the ruminant, and it coils. Okay, so that's just something a little different. You probably should remember. We also have the jejunum, which is the longest portion, and it allows for a great range of motion. This is often moving. If you were to do a surgery on an animal that is a healthy intestine, you can actually watch it as peristalsis moves it through the body. The ileum, and I'm going to show you this, it's very cool. It's a very short segment that happens right before the cecum. And there's a vessel that is called the antimesenteric vessel that starts where the ileum starts. So it's kind of like somebody has drawn a line on the ileum to show you where the change is from the jejunum to the ileum. And we'll show you this in dissected animals. So the ileum is separated from the colon by the ileocecal sphincter, And that cecum is like a blind sac, and within that sac there's a special part of digestion that occurs. It's a little bit of fermentation. And in herbivorous animals that are also monogastric, like the rabbit or the horse, this is where a lot of the digestion occurs and the absorption occurs of this plant material. So that cecum is very important. So this ileocecal sphincter will regulate the movement from the materials of the small intestine into the colon or the cecum. Looking at the cross section of the intestine, you will have an inner mucosal layer. Remember that mucosa will protect the epithelial cells. We'll have a submucosal layer, a muscular layer that helps us with the peristalsis, and the outer serosal layer. There's a relative thickness of layers that differs in each segment of the intestine. Remember, it's parasympathetic stimulation that occurs in order to move, for intestinal motility, for secretions and blood flow. Parasympathetic means rest and digest. Sympathetic stimulation decreases blood flow, but it has little effect on motility. But the decrease in blood flow will affect that motility over time. So sympathetic is for fight or flight. We don't need to rest and digest. So here's the mucosa, okay? Here's the thick muscle layer, and here's the serosa on the outside. Again, mucosa, submucosa, muscularis, serosa. And here's the mesentery. The mesentery is a sheet of connective tissue in which blood vessels, lymph vessels, and lymph nodes and nerves will innervate the intestine. And that sheet is apparent in all of the intestinal tract. And we will see that with our dissection. Within the mucosa, there are many folds and villi, okay? This villi is a finger which projects up into the lumen, or the hole that goes through the center of the small intestine. And each of those villus, or each villus, contains thousands of microvilli. It's also called a brush border because it's like little hairs on top of this. So just imagine how this increases the surface area for digestion to occur. These microvilli have digestive enzymes and carrier molecules embedded in the cell membranes, and that's what takes those little bitty teeny tiny nutrients from your food into your blood system. Between the villi, there are crypts, okay? Crypts are not this, okay? These are small intestinal crypts, okay? They're invaginations of mucosa around each villus, and they produce cells that are pushed up from the bottom of the crypt up to the villus to replace the older cells that are shed at the tip of the villus. There are also goblet cells here. Remember what goblet cells do? They produce mucus. That helps to protect the intestinal mucosa. So these crypts produce more cells, younger cells that come up to the villi, and on the villi that have microvilli, or the mucosa, or the brush border, will help increase the digestion. Now this is important to remember because it's the villi that are often attacked by diseases. And when we have sloughing of that of those villi, or sloughing of the intestinal, the lining of the intestine, that can cause a lot of damage if we haven't gotten really good cells to replace those very quickly. In the ileum, we have, in conjunction with goblet cells, we have little aggregates. Goblet cells make what? Mucus, right? So we also have little aggregates of lymph nodules that are more abundant in the ileum than any other part of the small intestine. Their prominent arrangement in the ileum has led to the term Peyer's patches to distinguish them. So there are little lymph nodules within the ileum called Peyer's patches. Peristalsis. Peristalsis is associated with the coordinated contractions of the longitudinal and circular muscle layers, and they're stimulated by reflexes in response to dilation of a segment of bowel. This can occur independent of the parasympathetic nervous system. So we don't need the parasympathetic nervous system to get our intestines moving. So what happens, we get a dilation of a segment of bowel, it increases, and then it increases to a certain degree, and then we'll get a reflex that contracts it again. So increase, decrease, increase, decrease. Okay. We also have cholecystokinin and prostaglandins that could also stimulate intestinal motility. So it is important for our intestines to be mobile and to continue moving. So there are a lot of different things that can make it happen. Another video for you to watch that just shows you, it's very descriptive of the segmental contractions that help to mix intestinal contents. Some of these these contractions can slow the movement of things through the intestine so that it can mix a little bit more and mix the digestive enzymes with the intestinal contents and bring those digestive materials into contact with the surface of the intestinal tract for absorption. So our intestinal tract is really geared toward absorbing as much as possible of the nutrients from the food. Electrolytes, water, and vitamins are all absorbed intact across the small intestinal wall. They're small enough and they enter into the intestinal wall very easily. Carbohydrates, proteins, and fats must be chemically digested first. Chemical digestion involves both enzymes in the lumen, or in the center of the intestine, and also enzymes associated with those microvilli. Carbohydrate digestion is when starch is converted into disaccharides into the lumen of the duodenum, or in the lumen of the duodenum, by pancreatic amylase. Amylase, very important that you remember that breaks down carbohydrates. And amylase comes from the pancreas. Disaccharides are further digested by enzymes in microvilli cell membranes, and this results in monosaccharides, which can be transported across the microvilli cell membrane and absorbed into the blood. Protein digestion, remember, it starts with that gastric pepsin, which breaks apart some protein chains into smaller polypeptides. There are 5 pancreatic proteases, things that will break down proteins. They include trypsin, chymotrypsin, elastase, aminopeptidase, and carboxypeptidase. These peptidases are proteases or proteases. They partially digest these peptides. Partially digested peptides are further digested by the peptidases in microvilli in the cell membranes. Amino acids, dipeptides, and some tripeptides are then absorbed across the cell membrane. So they have to be broken down into either individual amino acids or in groups of 2 or 3. Fat digestion. Fat, it's digested a little bit differently. There's agitation in the pyloric antrum in the stomach that breaks those fat globules or triglycerides into small droplets. There are bile acids that come from the gallbladder that comes from the liver. Those bile acids coat the fat droplets in the duodenum, and then the pancreatic lipases from the pancreas penetrate bile acid coating. It digests fat molecules to produce glycerol, fatty acids, and monoglycerides. These little droplets fragment into smaller particles called micelles. Micelles are a bile acid lipid component that is absorbed through the microvilli. So it's broken up into several little particles, and we need to remember that we have these little tiny micelles, and it's those micelles that are actually absorbed through the microvilli. Again, I've got another video for you to watch. Take your time, watch the video, understand a little bit better. With the large intestine, the components of the large intestine are the cecum, which is a blind sac at the ileocecal junction, the colon, which has some microbial digestion occurring there, and the rectum. There are some species variation in structure. We'll cover those a little bit, but they do all have the same primary function, which is to recover fluids and electrolytes from the lumen of the intestine and to store feces until they can be eliminated. Now, the longer feces remains in these areas, the more fluid and electrolyte can be absorbed and the drier the feces becomes. Carnivores typically have a simple, short, tubular colon and a very poorly developed cecum. When we're just digesting meats, we don't need as much fermentation occurring. In non-ruminant herbivores, like the horse or the rabbit, they have a very large colon and cecum. Or the cecum is also referred to as a hindgut. These guys are called hindgut fermentators. This is where fermentation happens. In the ruminant, it happens in the rumen. In the rabbit and horse, it happens in the cecum and the colon. All right, so hindgut digestion. Equine, guinea pigs, rats, rabbits, there are modifications of the cecum and colon that allow for fermentative digestion in the hindgut that is similar to the rumen. There are volatile fatty acids which are produced by microbes absorbed from the cecum and the colon, and they're used for energy needs just like they are from the rumen in ruminants. So if you remember what I said about why the rumen is important for ruminants, they can take really poor food and the microbes can turn that poor food into high energy bacteria that can be used for energy for the body of the animal. There are acids. These acids are buffered by secretion of bicarbonate, which are secreted directly into the colon and the cecum. In the horse, they have the largest and most complex large intestine of any domestic animal. And even though the diet of grass requires the assistance of microbes for digestion of the celluloses, the horse's digestive system defers fermentation until digested food reaches the cecum. And it has about 33 liters, in which it is an average capacity of the cecum. So it can be huge. These are also called post-gastric fermentators. So even though they absolutely need to ferment this grass in order to digest it, that doesn't happen until it gets to the cecum. The rectum is the terminal portion of the large intestine. It has a nervous system control of motility and secretions that is similar to that of the colon. There are numerous mucus secreting glands that lubricate and aid the passage of contents. And there are sensory receptors that detect stretching and stimulate the defecation response. So when stool enters this rectal area and stretches the rectum, that's when we have the need for defecation. The anus is considered the external opening of the intestine. It is composed of internal and external muscular sphincters. So it has two doors to control the exit of the feces. Internal sphincter is under autonomic control. We do not control that. External sphincter is under voluntary control. Now, infants and small animals typically don't have a lot of external control yet, okay? They don't learn that voluntary control. They don't have those nerves there until a little bit later. So some of it is autonomic control. As the rectum distends, those stretch receptors in the rectum will cause partial relaxation of the internal sphincter. So with babies, infants, you'll notice that stool doesn't just fall out until we have enough stool and we have a good bowel movement, okay? So it doesn't enter the colon and then exit it immediately. There has to be an accumulation before you'll have that relax and open up. There are anal mucosal receptors that increase the sense or need for defecation. So when we have that sense, that comes under voluntary control. The liver, what is so important about the liver within the digestive system? Well, a lot. The liver produces bile, bile acids, cholesterol, and bilirubin. This is secreted into bile ducts and then on into the hepatic duct and then into the gallbladder for storage. It is stimulated by cholecystokinin, CCK, and that causes the gallbladder to contract, and that occurs when an animal has eaten a meal. This forces bile down the common bile duct into the duodenum. The liver also removes toxins, infectious agents, and so forth so that it enters the body through the wall, or any of these infectious agents that enter the body through the wall of the GI tract. It can also store or metabolize nutrients that are absorbed from the GI tract. So it does three different things. Now, when it's taking those toxins out of the body, it's usually a lot of times taking it out of the body, excreting it through that bile that goes through the bile ducts to the hepatic duct into the gallbladder and into the duodenum. So you can see how that works. The pancreas is there for the production of pancreatic amylases, proteases, and lipase. So you got to remember what those things break down. Amylase breaks down carbohydrates. Proteases, easy, breaks down proteins. And lipase breaks down fat. It also secretes bicarbonate into the duodenum. Remember, it needs to buffer or neutralize the acidity of the contents and maintain the pH of the duodenum that's needed for proper enzyme function. It also, on the endocrine side, produces insulin and glucagon, which help to regulate blood glucose levels, which helps to regulate our energy level. All right, lots to go over. I recommend you go through this again, watch the videos, get comfortable with cholecystokinin and pepsin and gastrin and hydrochloric acid and chyme and all those words so that you know where they occur in the digestive tract. Bring those questions to class and we will answer them.